Welcome to another episode of Medicine Simplified. In this video, we will know about gastroparesis. What is gastroparesis? Gastro means stomach, paresis means partial paralysis. It is a condition of delayed gastric emptying in absence of mechanical obstruction. So, in this condition, the contents of stomach empty slow. It is a disorder of ineffective neuromuscular contraction, that is peristalsis of stomach, resulting in food and liquid remaining in the stomach for prolonged period. The food in the stomach remain for prolonged period. It involves parasympathetic and sympathetic nervous systems, gastric smooth muscle cells, pacemaker cells within the stomach and intestine, and pyrolic sphincter. Opposite of this condition is known as dumping syndrome, where stomach contents exit quickly into duodenum. Coming to the etiology, most of the cases are idiopathic, and second most are diabetic gastroparesis, especially type 1. Post-surgical complications like injury to vagal nerve. Post-infection causes like gastroenteritis, infectious mononucleosis, adrenal and thyroid gland problems. Rheumatological diseases like amyloid neuropathy and systemic sclerosis or scleroderma. Some medications can also cause gastroparesis like opioids, cyclosporins, phenothiazines, dopamine agonists, alpha-2 adrenergic agonists, tricyclic antidepressants, calcium channel blockers, GLP-1 agonists or analogs, lithium and progesterone. Gastroparesis has been associated with connective tissue disorders such as Marfan syndrome, Loeys-Dietz syndrome, and Ehlers-Danlos syndrome. This is due to laxity of stomach and gastrointestinal tissues. Coming to the symptoms of gastroparesis, most common is nausea and vomiting, early satiety, feeling full after eating only small amount of food, bloating and abdominal pain, acid reflux or heartburn, unintentional weight loss and malnutrition. Coming to the evaluation of gastroparesis, first we have to perform some basic laboratory testings like liver function test, complete blood picture, lipase test, HbA1c for diagnosing diabetes. Next, we will perform abdominal imaging like CT, MRI, GI endoscopy to rule out other GI disorders. Next diagnostic method is Scintigraphic gastric emptying studies, in short GES. It is a gold standard for detecting gastroparesis. In this diagnostic method, solid or liquid radioisotope, most commonly used is technetium-99 sulfur chloride, is added to meal to measure gastric emptying. Based on scintigraphic gastric retention of contents, after 4 postprandial hours, gastroparesis is graded as 3 types: mild, less than 15% retention; moderate, 15 to 35% retention; severe, more than 35% retention. Next diagnostic method is gastric emptying breath test, in short GEBT. It is a non-invasive method. In this method, a stable isotope, that is carbon-13, is incorporated into substrate, usually spirulina. After some time, the breath is measured using spectroscopy. The use of GEBT is limited in patients with liver or lung disease. Wireless motility capsule. This is the most advanced diagnostic method to diagnose gastroparesis. The utility of wireless motility capsule is limited by cost, availability, and poor correlation with gastric emptying of food. There are many other factors which can contribute to mobility of capsule. The capsule is indigestible solid and estimated sensitivity of 59 to 86% and specificity of 64 to 81% for gastroparesis. Coming to the treatment and management of gastroparesis, most important is dietary adjustment, eating 5 to 6 small, low fat and low fiber meals a day. Because fiber and fat are harder for stomach to process, we recommend low fat and low fiber meals. Liquid or pureed diets are frequently recommended for severe flare-ups. If retention is more than 35%, we recommend liquid or pureed diets. Coming to the medications, antiemetics such as fluclorazepam 5 to 10 mg up to thrice daily, diphenhydramine 12.5 to 25 mg up to 4 times daily, and ondansetron 4 or 8 mg up to 3 times daily can provide symptomatic relief in gastroparesis. Prokinetics like metoclopramide or erythromycin can help stimulate stomach muscles alongside anti-nausea medications. So both anti-nausea and prokinetics are recommended in gastroparesis patients. Next is surgical options. In severe cases, procedures like intrapyloric Botox injections, placement of feeding tube, or gastric electrical stimulators are required. Gastric electrical stimulation decreases the frequency of vomiting and need for nutrition supplementation. Coming to the differential diagnosis of gastroparesis, functional dyspepsia, gastric outlet obstruction, cyclical vomiting syndrome, rumination syndrome, cannabinoid hyperemesis syndrome, psychiatric disorders which include anxiety neurosis, anorexia nervosa, or bulimia could have persistent upper GI symptoms confused with gastroparesis. If you like this video, please subscribe to our channel. Thank you.